I'm at Mayo, and I'm a professor of neurosurgery, orthopedic surgery, and health services research. And I'll talk to you about the Mayo Clinic neurosurgery registry. Our registry is a little bit of an interesting thing in that it's multi-site, multi-state. So we have hospitals in Florida, Arizona, Minnesota, but also throughout the Midwest in Wisconsin, some smaller health clinics in Iowa. And so we built a team representing all those different sites in order to stand up a registry effort across our institution. We do have a large data analytics team, and it's a significant team and a significant effort and a significant cost, frankly. But that's been an important part of what we do and what we're able to do. The project overview there, so we have 25 neurosurgeons in the Midwest, and the numbers are a little bit outdated. We have 12 in Arizona and 14 in Florida. And our neurology departments are a lot bigger. I think we're at 130 neurologists in Rochester, which is more than the whole country of Canada. Which is interesting. And Olmsted County doesn't need 130 neurologists, it needs like one. But it's a unique and interesting practice. And so in our departmental registry, we take in patient-reported outcomes, clinical data, and we have, as of last year, the numbers are higher now, 48,626 patients. And so we've built dashboards, for the department, and the reason that we did this is, as you guys have experienced in your own institutions, a lot of times you don't have the data at your fingertips, but we did it so that the data could be at our fingertips. And so we can look at volume across a surgeon, across the entire institution, across, we could look at it in many different ways, across groupings, patient-reported outcomes. And so we can look at patient-reported outcomes, again, across any category: surgery, surgeon, location, site. This is the one, this to me is the slide where, kind of the rubber hits the road. This is the actual quality outcomes. And so I could tell you exactly how many mortalities we had across any number of categories, exactly how many complications we've had, exactly how many return to ORs and readmissions. And then we could dig into those and understand why each of those exist in that way. We did combine implant and cost data. I don't know why. Mayo made me black out the cost data. I honestly don't know why. It's actually federally, thank God, now required to be on a website. It's just a complicated website, so nobody knows how to dig through it. But literally, you can go on a website in theory and find all that data. We have quarterly departmental reports that are shared with our department leaders. And then, you can see there for our spine cases, outcomes and complications. You can see that over this period of time, we had, 88 complications in spinal surgery at a 5.5% rate. And we can dig into those exact 88 cases and find out exactly what happened. Predictive analytics, this is really neat. You could take a patient and enter some very basic components to that case, and then you could tell the patient, we're going to do your cranial or your spinal surgery, based on their specific areas, and you have a risk score of 6.59%, and you could tell them the exact complications that they may have. So that's, personalized. And people thought, well, that would scare patients. Who wants to read that list? But patients feel like they're part of shared decision-making when you give them that and appreciate that. And the registry that we built, we have 3 different chairs. We have Rob's our chair in Rochester. We have Alfredo and Bernard our chairs in Florida, Arizona. Fred is our enterprise chair, so he calls himself the supreme leader. So he's our supreme leader, so to speak. And so Fred and I published a Harvard Business Review article on this, about lessons from Mayo Clinic on using data to improve surgical outcomes. And I can show you briefly before ending a few projects that we've been able to do off of our institutional registry. We stood up a 3-site robotic program in 2018 that I helped lead. And, we can give you data from all the sites about that program. We've looked at sort of a neurosurgical practice, our experience as a center in terms of standardization of outcomes. We've looked at spinal injections. This project I love. I won't get into the details of it, but basically too many injections over a certain period of time will result in increased infections. And we're seeing more and more patients with many, many injections. I even had a case recently of iatrogenic osteoporosis in a young patient who had 16 injections. And so there's a real consequence to those. And then looking at postoperative depression and readmission rates following spine surgery, so the impact of depression in readmission, which I didn't think this would be related, but it is, and we saw a twofold increase, that patients with baseline depression are more likely to be readmitted to the hospital. And so, you're going to hear a lot more today about the different things that we do, and you're going to hear a lot about machine learning algorithms and predictive analytics and then obviously, generative AI. But there's a lot of automation and utilization of this data. But exactly, as Steve said, you are what you eat. So if the data is not curated, and as you see, we have a lot of personnel that curate that data, including nurses, then you end up with results that may not make sense or may not match reality. Thank you.